Assalamu alaikum everyone. The next topic of discussion is a platelet disorder known as von Willebrand disease. Von Willebrand factor have specifically two roles. One is platelet adhesion that bind with the GP1B receptor of the platelets, and another function is that it prevent the degradation of factor VIII. It is the most common congenital bleeding disorder, and on the basis of etiology, we have mainly two types, inherited and acquired. Inherited, we have further types, type 1, type 2, and type 3. Type 1 is, it compromises about 80 to 85%. Type 2, 15 to 20%, and type 3, approximately 3%. So von Willebrand disease inherited type is caused by mutation in the von Willebrand factor gene. It is usually autosomal dominant. In some cases, like in type 3, it can present as autosomal recessive, but usually it is autosomal dominant. In type 1, we have mild to moderate deficiency. In type 2, we have dysfunctional von Willebrand factor. In type 3, we have complete absence of the von Willebrand factor and factor VIII. Because von Willebrand factor protect the factor VIII from degradation, when there is deficiency or absence of the von Willebrand factor, so factor VIII will also be decreased. Then we have acquired type, so that occur usually secondary to other medical conditions like lymphoproliferative and myeloproliferative diseases, multiple myeloma, monoclonal gammopathies, lymphomas, and essential thrombocythemia. Then we have autoimmune diseases like SLE, cardiovascular disorder like VSD, aortic stenosis, hypothyroidism, and side effect of certain drugs like valproic acid. And its underlying mechanism is unknown, but it's thought to be immune mediated, which leads to antibodies production. Then we have pathophysiology, so deficiency or dysfunction of one Willebrand factor lead to one, there will be dysfunction platelet adhesion, so adhesion will be impaired, and there will be impaired primary hemostasis. Then we will have reduced binding of factor VIII, so there will be increased degradation and decreased factor VIII activity, lead to impaired intrinsic pathway of secondary hemostasis. So one, we have impaired primary hemostasis, and another, we have impaired intrinsic pathway of secondary hemostasis. What will be the presenting features? So the severity of symptoms vary between the different types, like type 1 and acquired usually manifest with more mild. Type 3 is the most severe because there is complete absence. Often asymptomatic, symptomatic individual may develop the following symptoms. Like there will be mucocutaneous bleeding, superficial bleedings, like ecchymosis, easy bruising, epistaxis, bleeding of the gums, petechiae, and there will be prolonged bleeding from the minor injuries. So in case scenario, there will be given like bleeding from the minor injuries. Bleeding after surgical procedure or tooth extraction, GI bleeding, menorrhagia like heavy bleeding, heavy menstrual bleeding. Then we have postpartum hemorrhage because during pregnancy there are increased level of one Willebrand factor which prevent the bleeding, but after the end of the pregnancy, the one Willebrand factor level decreases, so leads to postpartum hemorrhage. Severe cases, there will be large hematoma and hemarthrosis, like bleeding into the joint and life-threatening bleeding, for example, during childbirth. How to diagnose? So there will be given the recurrent episodes of bleeding history since childhood because it's most commonly inherited and autosomal dominant, and there will be given often a positive family history. On lab, you will have increased bleeding time. So remember, when there is decreased number of the platelets or the function of the platelet is impaired, like adhesion, aggregation, so bleeding time will be increased. Normal or increased APTT. APTT is prolonged when there is involvement of the intrinsic pathway. So factor VIII is usually decreased in von Willebrand disease, which leads to increased APTT. And the PT and the platelet count will be normal. So bleeding time will be increased, but the platelet count will be normal, and there will be normal PT. Because PT is increased when the extrinsic pathway of the coagulation cascade is affected. There will be decreased factor VIII level, decrease von Willebrand antigen level, and on aristocytin cofactor assay, there will be failure of the platelet aggregation or aristocytin cofactor level will be less than 30 international unit per deciliter. Further qualitative assessment by collagen binding assay. Aristocytin is antibiotic that activates von Willebrand factor to bind glycoprotein GP1B, thereby inducing platelet aggregation. Failure of the aggregation after adding aristocytin can be seen in patients with von Willebrand disease and Bernard-Solier syndrome. And Bernard-Solier, we have defective GP1B receptors. Now into the treatment. So treatment is only indicated if symptom occur or as prophylaxis before surgical procedure. In inherited von Willebrand disease, desmopressin stimulates von Willebrand release from the endothelial cells. This is the best initial treatment for mild or moderate symptoms, typically type 1 and sometimes type 2, not effective for type 3 because there is complete absence of the factor, so it doesn't have any beneficial effect. Concentrates containing von Willebrand factor and factor 8 indicated for severe bleeding as prophylaxis, and if desmopressin treatment is ineffective. Other treatment options include antifibrinolytics like aminocaproic acid, tranexamic acid, OCPs for menorrhagia, oral contraceptive pills for heavy menstrual bleeding. In acquired von Willebrand syndrome, desmopressin and von Willebrand factor 8 concentrates are often less effective than inherited. So patient may benefit from IVIG because usually underlying cause is autoimmune problems and treat the underlying cause. Platelet aggregation inhibitors like aspirin, NSAIDs, clopidogrel, and IM injection are contraindicated in von Willebrand disease because they further increase the risk of bleeding. So that's all about von Willebrand disease. Remember in von Willebrand disease, these are the main points like increased bleeding time, normal or increased APTT, and normal PT and platelet count. And there will often be a positive family history and recurrent episodes of bleeding since childhood.